I always explain recurrent miscarriage in you have a box, and the box is divided into two. 85% of the pregnancy, no matter it's natural, insemination, or fertilization, 85% is the chromosomal, the genetic healthy of the embryo. And the rest is a house. So what's going on in the house?
It's so much easier in a 20-something to start to course correct hormones than it is in the 30-something. And especially as we get older and nearer to perimenopause, it can be more difficult to make those corrections. And so do you feel like some of these really lend themselves to people not getting the extensive investigation they need about their own reproductive health?
Dr. Gerardo Barroso Villa
is a world-renowned fertility expert and reproductive biologist with an impressive pedigree.
Trained at prestigious institutions like the Jones Institute for Reproductive Medicine and Cornell University.
With advanced expertise in microsurgical male factor treatment and IVF techniques, along with a doctorate from Eastern Virginia Medical School.
Dr. Barroso has over 2,500 international citations for his research and serves as an ad hoc reviewer for leading medical journals.
A member of esteemed medical academies and a national researcher for the SNI, he is a leading force in reproductive medicine.
Known for his cutting-edge approach and unwavering commitment to advancing fertility science.
When you look at sperm, KPIs, DNA fragmentation, what are you looking for? What should people know that if their doctor has run some of these tests, that, if you've got these parameters, we need to intervene? Welcome back to the Dr. Brighten Show. I'm your host, Dr. Jolene Brighten. I'm board certified in naturopathic endocrinology, a nutrition scientist, a certified sex counselor, and a certified menopause specialist. As always, I'm bringing you the latest, most up-to-date information to help you take charge of your health and take back your hormones. If you enjoy this kind of information, I invite you to visit my website, drbrighten.com, where I have a ton of free resources for you, including a newsletter that brings you some of the best information, including updates on this podcast. Now, as always, this information is brought to you cost-free, and because of that, I have to say thank you to my sponsors for making this possible. It's my aim to make sure that you can have all the tools and resources in your hands and that we end the gatekeeping. And in order to do that, I do have to get support for this podcast. Thank you so much for being here. I know your time is so valuable and so important, and it's not lost on me that you're sharing it with me right now. Don't forget to subscribe, leave a comment, or share this with a friend because it helps this podcast get out to everyone who needs it. All right, let's dive in. Dr. Barroso, welcome to the show.
Thank you.
I'm so excited. I was sharing with people that somebody was putting a baby in me, and it was you, and you're not my husband. And I'm like,
sounds weird.
It's so weird, right? When I said it, I was like, this is so weird. But then all of these women started sharing. They're like, here is the woman who got me pregnant. And they were sharing their doctor, and they're like, yeah, I thought the same thing, but I never said it out loud because I didn't want anyone to think I was weird. And I was like, well, I'll say the weird things.
Oh, thank you.
But you're him. You're the guy, and you're here. And I'm so excited. You are.
Yeah.
So we're going to be talking today about some of the newer technologies in IVF. And I think we have really exciting things to cover. But I think where we should start is talking about the concept of unexplained infertility, the definition of fertility. And I'm curious from your perspective, when couples are told it's just unexplained, how often do you think they're getting as thorough of a workup that you do or going through some of these technologies?
Thank you so much. Let me start with the definition of infertility because we have a misconception. Let me tell you. Infertility become a definition as a disease in 2010, according to the WHO. And you have to try for a year and see what's going on before you start looking for a diagnosis, using any tool for treatments. But besides that, we have to wait a year, 6 months. It's more dynamic. Let me explain you. If you have a couple, 38 years old, one ovary with some endometriosis, and you have something in the sperm, do you really are gonna wait for a year to start doing something? The other side, you have a couple 26, 25, the both of them, and she got an anti-Mullerian hormone. The ovarian reserve is very low. Yeah, and PCO. We have a polycystic ovary. You have overweight. You have all these hormones running all through, and the quality of the egg we know is not the best to get pregnant. So, under my point of view, is doctor, because it's not the reproductive doctor, your first contact.
Yeah.
Mainly it's your primary or the gynecologist, but they just have a perception. And the perception kills because you really don't have the real picture of what's going on under the fertility condition. So for me is by the time you are clear, you got to get pregnant, you're looking for a family, start doing your research. You have to see if everything is working well, not because you're looking for something bad. It's really everything working well. The sperm is working well. You have your tubes working well. You have any infection, STD, or endometriosis, or if you have some overweight, you're related with polycystic ovary. So we have to define that everything is working as natural as we're looking for. If it does, well, we can look for a specific treatment, and maybe will be some medication for your thyroid or some antimicrobial drug for infections. Yeah. But if you have your tubes obstructed, you're not going to try for a year.
Yeah.
If you have a very low count of sperm, we have to do something before that. So, as I said, we have to get as far as we can the real picture for the fertility field.
Yeah. And I appreciate, so a few things that you brought up: hypothyroidism, being worked up, being looked at, polycystic ovarian syndrome, as we call it in the States, and endometriosis. These are two leading causes of infertility. And we know that these conditions often go overlooked, underdiagnosed, and so often women go to their doctor and they really get triaged in this way. The doctor says to them, do you want to have a baby right now? And if you say no, then your irregular periods, your acne, your painful periods are often met with just birth control. And that woman is never told, well, you do need to think about your future fertility. And so I appreciate you bringing that up, because if you are 20-something and you know that there are signs of PCOS, it's not best just to delay and to think, well, like a lot of doctors tell women, like, we'll just deal with it when you want to get pregnant, because insulin resistance can keep going, the testosterone issues, how it impacts regular ovulation. And it's so much easier in a 20-something to start to course correct hormones than it is in the 30-something. And especially as we get older and nearer to perimenopause, it can be more difficult to make those corrections. But the other thing I'm hearing you say is that it's not just the female factor we have to think about. We also have to think about the male factor. So I definitely want to get into that more today. And I'm going to have some questions for you about sperm and testing. What I am curious about, so the definition of infertility being if you're, in your 20s, under 35, you try for 6 months and you don't get pregnant, or over 35, you try for a year, you don't get pregnant. And the other thing I wanted to bring up is recurrent pregnancy loss. So often it isn't until your third, fourth miscarriage that a doctor will finally say, well, maybe we should look into why that is. And so do you feel like some of these really lend themselves to people not getting the extensive investigation they need about their own reproductive health?
Yes, they do. When we talk about endometriosis or polycystic ovary, everything is related, and infertility is a chronic disease. It's related with time. 40 years ago, there wasn't any infertility. Doctors doesn't know about endometriosis, polycystic ovary. is a new entity. Why? Because our grandparents, they got pregnant before the 20s. And around the 30s, they ended with the conception to get a family. Today, we delay the time. So with this, everything comes in a chronic condition. Endometriosis, growing continuously. Polycystic ovary related with insulin resistance is even worse. And today, if we don't have these underdiagnosed entities, we're losing the chances for a better quality lifestyle to impact over your reproductive issues. Like, okay, you have polycystic ovary. I have a doctor 20 years ago used to say, "Oh, I have a patient that is gonna be an egg donor, and he's a polycystic ovary, and they have 25 eggs." And say, "I'm so happy." I say, "I'm not, because the quality of the egg is very bad. For every 10 eggs we retrieve for those ovaries, only 1 or 2 are healthy." So it's really a condition that we have to expect. Today, it's not just doing in vitro fertilization. If you don't have the control for the weight, insulin resistance, supplementation, even before it start ovarian stimulation, you have 40% chances for not the best outcome during the treatment. So you have to do something before the treatment. We talk, you ask about miscarriage, recurrent miscarriage. I always explain recurrent miscarriage in you have a box, and the box is divided in two. 85% of the pregnancy, no matter it's natural, insemination, or in vitro fertilization, 85% is the chromosomal, the genetic healthy of the embryo. And the rest is a house. So what is going on in the house? Most of the time, the doctors say, by definition, you have to last at least 2 pregnancies before start looking for the problem. And I say, why? Why we have to do that? Even if you have the first miscarriage, take the tissue, make the chromosomal analysis, and see if everything was as expected. Some genetic abnormality means Down syndrome. But if it's not, where is the problem? We have to look at the house. Endometriosis. We have to see if you have any scars into the uterus. Most of the time in the United States, they have a previous miscarriage, or you have to use some curettage. So create some scars into the endometrium, and you can't see that. It's nothing you can see that. Yeah, or you have some blood disease like Thrombophilias. Okay, so we have to be in the correct side to look into the house or into the embryos. When in our population, thrombophilia is a real issue. We look for HMTRV. We look at the 2 to 3 factors related with the thrombophilia. Even though if you got pregnant and you have thrombophilia, you have the risk for prematurity or preeclampsia or other placental disorders. So we can, when we use the correct therapeutic tool, we have the chances to correct them, to get forward in the pregnancy, to get a healthy baby.
So I think this is a great time to talk about endometritis, because this can be a big contributing factor to recurrent pregnancy loss. This is something I know that you test for. I was tested for. So as we talk about endometritis, though, I think we should we should sparse it out with endometriosis, because people get those often confused. So when we talk about endometriosis versus endometritis, what are the difference between those? And what should people know about endometritis?
Well, it's a big difference. Endometriosis became for your regular mens. During that time, you expulse all this blood and tissue. Mm-hmm. But some of them have a reflux into the tubes. So all this blood goes through the tubes and reach the ovaries, the bladder, all the pelvic organs. Blood is very irritative. And every month, you have this reflux and create scars. At the beginning, no matter if you have, because we have stages from 1 to 4, to mild, moderate, or severe, no matter which stage you are, you have a chronic inflammatory condition. Mm-hmm. So, impaired with the motility of the sperm, the tube, the diameter of the tube is one of my hair.
Which is looking lovely after surgery today, I must say.
Right. So, increase the chances for blocking the interaction between the sperm and the egg. So we have to do something. Mm-hmm. The other side, endometritis. We know in the United States and many other countries, STD is a very pandemic condition. Mm-hmm. No one can escape from that. If you say, well, I check my vaginal cultures and everything is fine. Yeah, but it's not. For the last 20 years, we believe that the endometrial cavity was sterile. Mm-hmm. It was not.
No.
So we have to find we perform a specific test to look for those chronic infections. We call the ALICE. So the ALICE has the chance, it's very advanced genetic technique, where we can look into the cavity and find if you have this condition. Also, you have the infection. And for many times, we are people who likes to take some antibiotics for everything, for the flu, for the gastroenteritis. Yeah, but everything affects your microbiome.
Yes.
Your natural microbiome. So we require this balance into the microbiome, into the uterus. The lactobacillus has to be according for the healthy relationship with the embryo. Mm-hmm. So now we know that we have found that some of the patients, they have a great, beautiful genetic test embryos, they don't get pregnant. Mm-hmm. And they found that they don't have any lactobacillus. Mm-hmm. Or they have an infection also. Yeah, that is, when you repeat all this vaginal examination, we never found something. So help us to treat and make apart the infections and start looking to create the best environment for the embryo.
Mm-hmm. Well, I love that you bring up that what affects your gut health is going to affect the reproductive microbiome as well. And so people understand the gut microbiome, we want to be very diverse. Diversity is a sign of health. The endometrial microbiome, we want almost no diversity. It needs to be 90% predominantly lactobacillus species. And so you mentioned the ALICE test. So there's ALICE and EMMA. Those are done by endometrial biopsy. Is there any sign outside of that someone would know that possibly they could have endometritis without doing that testing?
Not really.
There's not. So why is it that we don't see more clinicians doing this testing, making sure that the health of the uterus is optimized, not just the health of the egg? I feel like when it comes to fertility, there's still so many doctors that reduce everything to just the egg. And I like to say that women are both the seed and the soil. We are going to provide the egg, but sperm matters as well, and we're going to talk about that. But there's also the soil, and the soil has to be healthy. The microbiome, as you mentioned before about supplements, your nutrients, the amount of inflammation, all of that can really determine whether that healthy embryo implants or not.
Yeah, I believe it's related with how the doctors are, they think in our organization. Let me explain. Sometimes it's not a medical issue. I started doing more than 10 years ago PGTA for everyone.
Okay, but define what PGTA is so people know.
Sorry,
No, it's all good.
PGTA is the test that help us to recognize some chromosomal abnormality, some genetic disease. Yeah. We have a 25% in our best conditions to get pregnant. And the question is why? It's because not of all the eggs or sperm is healthy. So when we have the half of the DNA for each one and cross all these chromosomes, you get a healthy embryo. For some conditions, you got not, like Down syndrome, Klinefelter, Turner syndrome. And when I were talking with my team, I say, we want to perform PGTA. All right. This pre-implantation genetic test, but some of the papers say should be over 38, or some of them say no more than 35. Yeah, this paper war. Yeah, that science
and
is
the society
not,
is every year saying something different.
It's different because science is not static and it's not perfect. But the decision is not related with science. It's related with information. As much information you get, you can decide. Because infertility is so many variables.
Yes.
If you got appendicitis, okay, make your ultrasound or whatever image tool you decide, and you have a diagnosis and a treatment. For infertility, you just have variables. You have factors. Yeah, and no one knows if you have to do surgery, laparoscopic, open, or insemination, or you have to try 3 to 6 months regular intercourse or insemination or in vitro fertilization. Why? You have to decide what is going to be the platform related with the information. So the decision is if you have as much information, you have the power for decision. If I know how is the microbiome, if I know if I have that endometritis, a healthy embryo with PGTA or Thrombophilias, our chances to get pregnant increase dramatically because is the percentage of of one population. Yeah, the patient don't want to be in statistics. You're looking for objective. So that's why we have to do as much as we can.
Yes, and that's why I love your approach because it's very data-driven. I'm a big fan of trying to gather as much data as possible, and it's very bio-individual. And I feel like so often I run into clinicians who are like, well, this is what the research says, and we just stick to that. And it's like, well, you have to interpret it in the context of the individual who's sitting in front of you. We can't just say, well, statistically speaking, this is what's true for somebody who's 35. Well, the like if we just look at who actually will go into studies, they're very different than the average human being usually. You look at even the studies that are done in like 20-somethings, they're usually college kids. They're living a very different life. So we have to understand that the individual data should be driving these decisions. And that's something I really appreciate about you. And, to your point about the endometritis, so I want to circle back to that, because I was reading statistics about it, miscarriages be related 20% of the time to the uterus, and 30 to 60% of the time we've got endometritis going on when there's been this recurrent pregnancy loss. So who would be at risk for endometritis, aside from maybe you had a really good time in college, you may have contracted an STI, but what puts you at risk for endometritis, and how do we treat that? How do we restore the microbiome?
As I said, if by the time you test, and you don't have to be infertile.
Mm-hmm.
I have a patient who she got pregnant. She delivered a baby. It was kind of complicated. And she got an infection after the delivery.
Mm-hmm.
She can get pregnant 2 years after that. And no one can find what was the problem. And we were talking, I say, yeah, how was your delivery? Was a C-section? Yeah, was a C-section, but I have an infection.
Mm-hmm.
I say, did you? Right. I performed EMA analysis. She got a pretty bad infection into the uterus. Just a chronic, not symptoms, not high temperature or something, and no lactobacillus. So we treat the infection and start doing our supplementation.
And we treat the infection with the antibiotics, so everybody's clear that there is a time and the place for antibiotics.
Always. When you treat an infection, you have to start with lactobacillus. You have to recover this microbiome because you're going to kill it. So 2 months later, she got pregnant spontaneously.
Mm-hmm.
Yeah, but you have to think. There is, I love to work with processes. My head is working in process. And in process, we define these KPIs, key performance indicators. For me, it's so easy.
Mm-hmm.
Yeah. My first...
This is where the MBA steps into the treatment room.
Absolutely. Absolutely. It's something that changed my mind because I always have a question for my team. I say, you are living in Mexico in a place we call Iztapalapa.
What does that mean?
Iztapalapa is a low resource population in Mexico.
Okay.
So you have 5,000 diabetic patients, and you only have 3 endocrinologists. How do you attend 5,000 diabetic people with 3 endocrinologists? And I say, we don't know. Well, what about if you have regular physicians, you have nutritionists, you have the therapists, and you have a protocols for each one. And you apply the one that required insulin or not insulin, is the medication, what kind of medication. Everything is in a process. And behind, for some really drastic condition patients, you have the endocrinologists. Yeah, but you have the problem with the doctor is you can do everything by yourself. We are very expensive subjects.
Yeah,
prepare a doctor, gynecologist, and in reproduction is very expensive, and also you just have some period of time to work. If you do it by yourself, you're gonna miss something. In our team, we have all these processes, and we have these KPIs.
I want to hear what these KPIs are. I'm very intrigued.
The first one is, how is your ovarian reserve? Okay, you are 28, you're 38.
And that was the AMH you mentioned earlier, anti-Müllerian hormone.
Anti-Müllerian, yeah. Please do something. Did you find that your anti-Müllerian hormone decrease? Is it time for looking for a pregnancy or free sex?
Mm-hmm.
If you are really certain that you're going to be mom or dad, okay? Second, always is a sperm. One of the first conditions for infertility is the male factor. We have a study from Belgium that they look from the sperm in males from 1920 to 1994, and they saw a decreasing on the 50% of concentration and motility. So we have to be sure that we're working with a good, healthy sperm or start doing something.
What do you think's impacting sperm?
A lot.
Yeah.
It's not just for looking for the positive pregnancy test, because 20 years ago, we do everything just to get a pregnant.
Mm-hmm.
Now, we're looking not just for the pregnancy, for a healthy baby, because the placenta came from the sperm.
Mm-hmm.
So now, in vitro fertilization babies, we know they born early, they have prematurity, they have diseases related with vascular disease as preeclampsia, and everything is related with the sperm. Yeah. So now we have to look, and we are doing not just the regular semen analysis, like the concentration or motility or morphology. We also can evaluate the fragmentation of the DNA and see how healthy or how it's going to impact during the embryo formation. Yeah. So, and we have another tools to select the right sperm. We use some, we call Pixie. We use hyaluronic acid to attach the more functional sperm before make the injection through ICSI into the egg.
And in ICSI, you choose the sperm under a microscope. You don't allow the sperm to choose to, well, let me back that up. The egg gets to choose the sperm in a normal environment. Well, I shouldn't say normal, but in the natural environment. And in the lab, ICSI is taking the sperm and actually choosing the sperm that will inseminate the egg.
Yes, it's correct. And we do ICSI for everything because we know already when something is not working well. Yeah. Could be a molecular diagnosis because in vitro, okay, you're looking for a treatment, but also it's a diagnostic tool. You can see in every step what is going on, and if you have to change something during the process. So at the end, we perform the ICSI because our last outcome has to be to get this healthy PGTA embryo before the embryo transfer.
When you look at sperm, KPIs, DNA fragmentation, what are you looking for? What should people know that if their doctor has run some of these tests that, if you've got these parameters, we need to intervene?
Usually, the parameters have changed for the last year. So if you have below 15 million of sperm motile, I mean, because you can have 15 million, you just move 10%. No, it's not working. Before that, we have to start thinking about insemination or even in vitro fertilization. But also, the question is, which one is better? Because in the school, everyone thought that you have to escalate like stairs. Like you try naturally, and then we're going to give you a pill, the Clomid, and then we're going to start apply some injections. And after that, we're going to do insemination. During the 80s, for the pregnancy outcome using IVF or insemination was pretty much the same, 20%. Today, you still have in unexplained infertility. For me, it's not unexplained, but this is because you're not looking right. But suppose you have unexplained.
Do your KPIs, people.
Yeah. You have unexplained infertility. You have your 20%. But today, with in vitro fertilization, we can reach over 70% chances to get pregnant. So, and in vitro fertilization is also very jealous, because when you start with this process to reach after 5 years IVF, you lose any chances for your ovarian reserve. The best chance for in vitro fertilization is when you have a really good number of eggs, good quality, you're young, and you have the best of you for in vitro fertilization. That's why always you have to decide which one is the best way for you, and it's not has to be just for the medical. People sometimes came and say, I don't have the guts to look for a pregnancy and see if it comes with some condition.
Yeah.
I have to be certain that it's healthy. I have a patient, a couple, let me tell you. They have this dwarf condition, these little guys with big hands. So this genetic condition that you can transmit in the 50% of the cases. So they came to me and said, we're going to do in vitro fertilization, PGTA, to look for this gene condition in the embryo. At the end, I got 2 embryos. One with dwarf condition and the other one with no dwarf condition, regular, normal, chromosomal condition. So we told them, we transfer the embryo, you say?
Euploid? Normal genetics?
No.
No?
They came
No, they
for
decided.
the dwarf baby.
Yeah.
Because they came from one population in Ohio that everyone was dwarf.
Yeah.
So they want the little dwarf baby because that is normal for them.
I love that.
Yeah.
That's a good story.
So it's impressive because you realize really what's normal.
Yeah.
What's normal in life.
Yeah.
So I learned a lot from this case.
I love that. So can we talk about supplements and about lifestyle? Because you mentioned for PCOS, and then we've talked about sperm health. So I'd love to know the top science-backed supplements for egg quality and then sperm quality, and especially in the context of if we're having DNA fragmentation issues.
I always say that the supplementation is important, but so people sometimes confuse that, put everything in the same line. So that you have to live in Mexico and you have the mercados. And these mercados has people who sell you some species on the in tea for fertility. And this is miracle. And I said, yes, everything is important, just put in the right way. So you have circles. That is important, your healthy embryo, your endometrial implantation, but your diet, your supplementation, according to for what you have. So lifestyle is important. Obesity is important. You have to control your weight. Sometimes the doctor avoid to talk about this because the patients can feel frustrated and do nothing around. But you have to do something.
Yeah. Well, and I think also when you go through the IVF process, I did so much to try not to gain weight. I gained weight after the 3rd egg retrieval. My endometriosis inflammation came on. And then I went on Lupron, which was a glimpse into how hard it is to be metabolically healthy in menopause. And I think that also makes it difficult because as a patient, and I'm glad that it brought humility into my life even more. I'm always grateful for it, where I'm I was doing everything right. But until I really got the hormones, the endometriosis under control and worked on all of that, did things start to shift? So I think you're right. Doctors don't want to talk about it. And sometimes patients, they don't want to hear it because they're like, I'm
Right.
trying. And it's like, well, let's work together on that.
Yeah, because obesity, endometriosis, PCO, everything is an inflammatory condition, a chronic condition. And they have this ability and impair the quality of your gametes. So even it's an egg or a sperm,
Yeah.
egg and sperm are so fragile
Mm-hmm.
in the men. If you don't sleep well, you have anxiety, you work so hard, you have some troubles with your weight. We have seen that is changing constantly. You know, it's not like the women like we can track with the anti-Mullerian and ovarian reserve and see how it's going on. I can perform a semen analysis today, and in 3 months can be different.
Yeah.
So
this like positive though, because that means that you can shift your sperm roughly 72 days to generate that. So if you're listening to this is what Dr. Barroso recommends for sperm.
absolutely. I mean, yeah, we have to live. We're gonna live longer.
Mm-hmm.
No matter what we do, we're gonna at least you have some real condition, cardiovascular or metabolic, cancer. But if we don't, we're gonna live longer. But at the end is under what conditions?
Mm-hmm.
Yeah, we have to take care of like doing some muscle today.
Mm-hmm.
Build muscle.
Yeah.
Helps with the insulin sensitivity,
Mm-hmm.
reduce your obesity, and realize that we have to do something better, not just for our fertility or our life. And in men is so because always we look at the woman and say you have to do A, B, C, D, and just the men just never say anything.
Yeah.
We never look at for the male factor, and we have to. Yeah, and we have to do some supplementation. For example, for PCO, there is very specific supplementation to this enofolic acid that increase the chances to get a better quality of the egg.
Mm-hmm.
I mean, it's not magic. It's not you're gonna start taking for a couple of weeks and wow, voila, you have a great eggs. Not, but we can start today. We can work on it, and it's the same for the sperm. Sometimes I recommend that not using the sauna or these guys that start in the bicycle 30, 40 kilometers a day because it's going to damage the quality of the sperm, even decrease the number. So I believe it's important.
And the sauna piece, so we know that as you bring this up and you were talking about cardiovascular health, frequent sauna use is associated with a reduction in cardiovascular related risks. So saunas do have lots of benefits, but in the scheme of fertility, when you're under that high heat, that can be problematic for sperm production.
Yes, it is. Yes, it is.
People are going to be mad if we take their sauna away.
I know.
Come on, you can do anything for a couple of months
Of
or
course.
reduce the time. And so riding bike, anything that can, be causing heat in that area. But also, I've seen, I remember in rotations seeing chronic proctitis just for people riding bikes. So people should be aware that there are certain things that they're healthy for all intents and purposes, but during fertility, it might not be the best.
Today, I'm using also hyperbaric chamber.
I almost did that before my egg retrieval, but I was having such a difficult time finding a place here. But do you do that before egg retrieval?
Yes, I do. It's behind the clinic.
Stop. See, I didn't even find your clinic. You have to get a better website. This is why we're doing this. People need to know about you. I didn't even know there was one right there. But hyperbaric oxygen, I want to hear about that. And I want to tell you a couple other things that I did that helped my egg quality. And we went from 0 embryos on the first retrieval to having 3 healthy retrievals by the third, or 3 healthy embryos by the third. But tell us about hyperbaric oxygen.
Hyperbaric is when you increase the atmosphere, when you breathe, the oxygen goes with the carrier, the hemoglobin.
Yes,
yeah?
The red blood cells.
So this one is this carrier, this little truck is going into the cell and gives the oxygen. When you are over 1.7 atmosphere of pressure, you don't need this carrier. By diffusion, the oxygen will go to the tissue and the cells. So what we're looking is to increase the oxygen into the follicular blood flow and in the endometrial receptivity, to have a more healthy cells before egg retrieval or before embryo transfer.
I'm like, why did we not do this? I went from sea level to Mexico City, which is like 7,000 elevation. I'm like, I should have done this.
Of course,
We're
naturally.
Good. It
naturally.
happened. Yeah.
Right.
So hyperbaric oxygen, do you recommend so many sessions before the egg retrieval?
I have my protocol.
Do you have it in front of you?
Yeah. Well, not my. When you go to the chamber, those guys has my.
Oh, okay.
Yeah, my protocol. So
Okay.
there's 10 sessions. Yeah, you got inside. You can sit with your partner and start looking for some Netflix movie or some because it's around an hour. Yeah, and it's working well.
Awesome.
Yes.
So the things that I did is I did NAD infusions. And so my first egg retrieval, I was shocked when we had no healthy embryos, no euploid. We made lots of embryos.
Right.
Like 15 embryos and none of them turned out. It was so sad. I remember I was in Paris and I was like, it's going to be the best. And then I got the results and I was like, how could anything ruin a time in Paris like this? Absolutely did.
Right. It was depressing.
But I went, I saw a friend. I actually went to London and saw a friend there. He has a clinic and I did NAD infusions. And I also started near infrared light therapy over my pelvis. And the next retrieval, we got 1, which is to be expected. So people know it's like 90 days. Whatever you do, you got 3 months later. So by the time we got to that 3 months later, that's when we got the 3 euploid. And so that NAD really helps supercharge the mitochondria. And that's where I focused my entire protocol around, is that if we can get the mitochondria healthy, it should, in theory, because we don't have tons of research on this, make for healthier embryo quality.
Right. So everything that can help us. You remember the PRP.
Yeah, I was going to talk about that next. So I'm glad you brought that up. So we did PRP. Well, let me have you explain. You guys don't say PRP here. You say the letters differently. But as soon as you were like, there's this treatment, takes your plasma. I was like, PRP, I'm in. Let's do it. It's something that Dr. Amy, the egg whisperer, she talks about. Like everybody who I think is leading in the field of fertility is talking about PRP, uterine PRP. So what is it? Why use it?
Yeah.
What's
PRP,
the magic?
It's a platelet-rich plasma. So it's an emerging therapeutic option in IVF. So what we do is during the preparation for embryo implantation, we took some blood from the patient, made the centrifugation to get some growth factors and some proteins to enhance the chances for implantation, to change the environment. So now I believe okay. We're working on it, and we have pretty good outcome, and it's so easy to get. You remember that we performed the sonogram, took the blood sample, and 20, 30 minutes later, we made the transfer for the platelets. So, I mean, I think it's a pretty good option, not really invasive. So, they're still doing some research. We're looking to measure some interleukin reaction to see if any modifications. So, working pretty good.
So helping with inflammation, improving the quality of the endometrium. And so people know the worst part about the entire thing is that you have to do it with a full bladder. And that's really, I think, the worst part. Because people are like, when I shared that I was doing this, people are like, they're going to like put a needle into your uterus. I'm like, no, it's not that bad. It's just a catheter and a little bit of fluid. And then you lay there for like 15 minutes just thinking about how you have to go to the bathroom. But so you've introduced this. Have you yet to do PRP ovarian injections?
Yes. And still on research. Is nothing today that proves that is really working.
Yeah.
And I say that because, unfortunately, some people doing these treatments with no chances for, they took the platelets, and after when you make the puncture on the ovary, after the egg retrieval, they inject it into the empty follicle. The thing is, how much of this platelet is going really through the ovary because it's already broke, So, and the thing is, you are creating an illusion that some patient with really, really low ovarian reserve is going to have 10 really good eggs. So we have to be so careful with this kind of therapy.
Yeah.
I stopped doing because we don't find a really significant outcome.
Okay.
Yeah.
Yeah. I know it's something that people are still researching and looking into. So maybe there'll be a different technique or a different way in the future, or maybe we're just not there yet. I do believe, and I hope it's in my lifetime, we will find a way to extend the life of ovarian function. It only makes sense with how long we're living. There was new research. There's a study actually going on, a trial for rapamycin. And I'm excited for that. I'm like, please get us answers before menopause is knocking on my door if this will work. So I think there are exciting things out there. I just don't think that we have prioritized some of this research in the way that we needed to. As you were talking about with PCOS, endometriosis, like that not really being considered as much until recent years about fertility because of the delay in which women were getting pregnant. And there's nothing wrong with that delay. Like I had my first child at 31 and my second at 40. And I'm like, I'm a better mom at 40. I wish that nature worked out to where I could just be a mom in my 40s because while I love the one I had in my early 30s, I'm like, I definitely am a better mom in my 40s.
We have to be very respectful because it's not just like 50 years ago that you're a woman just to have babies.
Yeah.
And be at home. It's so many things you have to do. And delay is an option. Now we can freeze eggs. That is something good. And I'm certainly sure that in the next 5-10 years, we're going to start using some therapeutic options to preserve in a physiological condition our ovarian reserve and the quality of those eggs. Today we are the mirror of that. My father at my age, he was a senior. Looks a really senior.
I mean, if you look at TV shows when we were kids, people our age were elderly.
Very.
It's crazy, right?
Yes, and we're not.
No,
we're doing something different.
Because we're building our muscle.
Of course. Yeah. Muscle is the organ for longevity.
Well said.
Yes. Yes, it is. So we want to live healthy and longer, start building muscle.
Absolutely. I agree with that. I want to go back. So we talked about Alice and Emma, but I didn't ask about endometrial receptivity. So that
Yes.
testing can be done at the same time. And this is all done via endometrial biopsy,
Yes.
which at your clinic, you don't subject people to being awake or not having pain management. In the United States, most of these are performed while women are completely conscious, not being given pain medication. And so I just want to say to people, there are options for clinicians who provide pain management if the mention of an endometrial biopsy makes you shy away. But ERA, what is it? Why should we do it? I imagine this is in your KPIs.
Yes, because we're looking for if we're looking for the house, we have to know that is a window during the implantation stage that we have to assess if you are in the right time for the right transfer. If you have a 5 years, 5 days embryo, it's around plus minus 120 hours.
Mm-hmm.
Sometimes we found that we displaced the window, and you're not 120. You may be 144.
Mm-hmm.
It's 20 hours that you have to wait before embryo transfer.
And it's not just waiting. This is how long you have to be taking progesterone and being
Right.
exposed to progesterone.
Everything is related with the
optimize.
progesterone.
Yeah.
Yes, with the starting of progesterone. So we perform. We found like 30% of our patients, they change this implantation window. So we follow that. So we have the embryo, healthy embryo. So now we're required to know where is the best time to put the embryo into the cavity.
And so with that, so I just want to talk about that these tests can be done all at once. You can understand, is there endometritis that has to be treated? With that, you were saying antibiotics, and then are you using vaginal and oral probiotics?
Yes.
Okay. So vaginal, oral probiotics, emphasis on lactobacillus, and then that data of the ERA is going to tell you how long you need to be, and you do vaginal progesterone in your clinic, how long do you need to be exposed to that progesterone to optimize the endometrium? And for people to understand that lining, it's not just about building it up and having the 3 layers, but it actually has to be receptive. It has to be, I like to call it like the nice down comforter, where you just like, you can't help but snuggle in. Like you want the embryo to be like, oh, it's so good. Like,
and beyond that, help us to evaluate some really hard conditions. I mean, you have sometimes the line, endometrial line is so thin, it's not growing. It's under 7 millimeters.
Yeah.
And you don't know if it's because it's not going to grow anymore. It's what it is.
Yeah.
So we perform the ERA, and if it shows we have receptivity, we put the embryo. It works. Other size, myoma. Myoma, when we talk about myoma, this benign tumor in the uterus, we always said if it's in contact with the cavity, we have to remove. Okay. But what about if you have not in the cavity, just in the body, in the muscular layer? You have 20, 25. It's a lot of myoma that they take away the blood that it can use for the perfusion of the embryo. Yeah. And you don't know if it's affecting or not. And you cannot make surgery, because at the end, if you took all of them, it's going to be like a Gruyere cheese, this cheese.
It's like adenomyosis as well.
Like the adenomyosis.
You can't just go and take it out, and it can cut off blood flow. So when you're saying perfusion, so people understand the blood flow to the uterus. And so doing an ERA can help you understand about the perfusion as well.
It's correct. So
yeah.
Something that we're doing before all that now with artificial intelligence, we can now start make a score for the eggs or for the embryos. Because
are we going to talk about magenta and violet?
Magenta and violet.
How about these names? I love the fertility names. There's Emma and Alice, Violet and Magenta.
Everything is so touching and romantic. Right? Yeah. Today, some people came and say, well, I'm going to freeze my eggs. All right. Polycystic ovary. Okay. Are they good?
Yeah.
Are they going to work? Because I want to wait for the next 5 years. But when they say it's working, we don't know, because we don't know the quality. We don't know until we have the other part, if it's compatible with sperm, and what is going to be the outcome of the embryo. And today, with this artificial intelligence, we can evaluate the oocyte quality to predict the likelihood of the success. I mean, so we have all the eggs, and you have a score. And you have 1 to 10 and say, okay, this one is 24, 68, or this is 9 to 10. But you have an idea that how looks those eggs. Sometimes in the regular work in the lab, they look like, oh man, we got those eggs, but the is granular and it's dark and doesn't look too good. Yeah. And sometimes it's hard to explain to the patients.
Yeah.
But with this platform, you have a score and you can say, okay, you have 10. From those 10, maybe 3 to 4, they're going to get an embryo until the blastocyst stage. So helps. This is with violet. And with magenta, do the same with the embryo. In the early stage of the embryo, we start looking for these KPIs in the embryo and see if the cell division, the symmetry, the fragmentation, something else that can predict if you're going to reach that stage.
Yeah. So what I love about the violet technology too is that it can also guide you. So I think it's really important if people are new to the world of IVF to understand, and there's a lot of misinformation that happens in the United States where people think that every healthy egg becomes an embryo and every embryo is healthy and that becomes a life. And nature is cruel. I will say that in nature, as you were saying, you're only going to get a quarter of those embryos will make it. So to have that guidance of, listen, this many eggs may become an embryo. And then we have to do PGTA on that. And then what's the percentage from healthy egg to euploid healthy embryo?
It depends of the quality of mainly the age of the patient.
Yeah.
We
hate that, but yes.
Right, yes, definitely. Because how do we know that? When you are around 30, maybe 45, 50% of your eggs have some abnormal genetic condition, but that when you reach the 40s, 85% of your eggs are in really bad condition. So we know that for a woman over 40, we require at least 15 eggs to get one healthy embryo. The question is, okay, how do we do that? Because at 40s, you already have a diminished number of eggs. Or the other side, I have patients, 42 years old, polycystic ovary, that they still have eggs.
Yeah.
And say, wow, I'm so healthy. And I say, maybe yes, maybe not, because we're gonna get those eggs, and we really have to see how healthy and if we can reach a healthy embryo. So it depends by age, some condition like PCOS, or some of them to reduce the number because they have endometriosis into the ovary. We call endometrioma, and the endometrioma is still growing, and it's your healthy your healthy eggs. So,
and in those situations, I think it's important for people to know that a gynecologist may recommend excision surgery of the endometrioma, but I always say that should only be done with an endometriosis expert because often they take too much of the ovary and there's been complications of that. And then you're essentially left with one ovary. I did want to ask, so if somebody wants to prepare for an egg retrieval, maybe they're going to freeze their eggs, maybe they're going to go the full, 9 yards and make an embryo. How do they get the best score? How do you gamify Violet and make the healthiest egg?
I believe this, as you say, if the question is, what if I have this endometrioma?
Mm-hmm.
You score from 0 to 40 when you have endometriosis. When you have endometrioma, you already have 20 points.
Mm-hmm.
So you are between moderate to severe disease.
Mm-hmm.
And the question is, okay, what is next? I want to keep my eggs before the surgery. Maybe I want to take my eggs and they try to restore the function of the ovary. Most of the time, they lose an ovary, your capacity to have enough eggs for whatever therapy seems to be insemination or in vitro fertilization. So we have to be certain that we're looking for. Yeah. But you say your question specific was...
So how can we gamify? Like biohack, as some people would say, or what are things we can do to improve the odds that those eggs are going to have the best score, that we are going to be stellar KPIs?
Absolutely. Lifestyle. Lifestyle is patience. I have patients, 18 years old.
Mm-hmm.
They don't even know that they don't have a boyfriend.
Yeah,
but they have endometriosis. So restore the endometriosis, do for the quality, give the medication, keep this inflammatory condition very low. So by the time they reach 25, 28, they're going to be good enough for, if they're looking for any treatment, we'll be fine. Also with polycystic ovary, they're young, 16, 17 years old. Where you're looking to look pretty because you have this androgen condition with acne and you have more hair in the face than me and the overweight. So you look to restore this phenotypic condition to look good and also work with your eggs. But if now you're looking for 10 years later, you're looking to have a baby, you start working before with your insulin resistance, you start taking your supplementation, understand that it's nothing but with your behavior. It's a condition that you're born like that, and if you are conscious that it's not what you're doing, because your friends, they are skinny and they eat 10 tacos and they still skinny, and you eat some tomatoes and lettuce and you increase 2 pounds, it's not you. It's your condition. So don't fight. So take your medication, keep in control, make the best that you can do for your weight, and everything is going to be so smooth.
Mm-hmm. How do you feel about CoQ10, N-acetylcysteine, alpha-lipoic acid? I could name a ton.
Everything helps, as
everything
I say.
Helps.
Yeah, CoQ10 is a very good antioxidant agent. But I mean, I have a patient during COVID, and he was like 200 pounds weight. And he said, hey, if I take vitamin G, it's going to help you with COVID. And I say, yeah, but you have to stop eating Cheetos, because he was eating Cheetos. And
in the treatment room with you?
I say, man, everything helps.
Yeah.
Vitamin D helps. But you have to do something before your supplementation.
Absolutely.
Yeah.
Yeah. So I love that approach of like, it needs to be the nutrition and lifestyle aspect before you add on the supplementation. So what, I just want to back up because I know this question will come up from people. What specifically about PCOS is affecting poor egg quality?
Insulin resistance. Insulin resistance. Because PCO, by definition, you increase the out layer of the ovary, and you have these tiny follicles, but you don't have any ovulation. So it's still there. Years ago, we used to do some ovarian drilling. Yeah. When I do surgery, I do so much surgery with endometriosis, and I use laser. So sometimes I do some drills into the ovary to help with some growth factors to help natural and spontaneous ovulation. So insulin resistance is one of them, and the androgens. Androgens is killing because it's the two cells theory that you have to produce more estrogens, but you have more, for your audiences, you have more male or hormones, and you require the female hormones, but the ratio is inverse. No, it's not working in the same level.
Right. And with PCOS, I'm curious, do you ever use myo-inositol?
Yes.
Yeah, I love myo-inositol.
Myo-inositol is really good. It's very easy to get.
Yeah.
Yeah.
The other thing I really like for endometriosis and for egg health is melatonin. That's something that people are like, why do you take melatonin at night? And I'm like, I take it for the endometriosis, not for my sleep as much. My kids run me so tired. I hit the pillow and I have no problem going to sleep. So I appreciate you talking about the aspect of PCOS, endometriosis. I do want to bring up something that I feel like you really are cutting edge on is using MRI to diagnose endometriosis. Can you talk a little bit more about that?
Absolutely. Endometriosis is underdiagnosed. So many people is living with endometriosis, not just for fertility, on pain. Yeah. And most of them, they have this blood inflammation in the gut, and they have one of my questions with the patient that I'm thinking they have endometriosis is during your period. Do you have diarrhea? Yes. And the husband say, I didn't know. Yes, I have that diarrhea. Okay. So it's not the doctor that I have to do some laparoscopic surgery or I have to open it to see if you have. No. MRI is the gold standard today for diagnose endometriosis, and also to make the stage of the endometriosis, because sometimes you go into the cavity and say, whoa, it's very bad. You were not prepared for the surgery.
Yeah.
So by the time you say you have endometrioma, and you have the ovary stick into the tube, and the tube is stick into the bowel, and going on and on, you have to go prepare for the surgery if the surgery is required. Yeah, because if you have symptoms, okay, you require it. Maybe if you don't, and it's a fertility stage, you just remove the inflammatory condition into the pelvic cavity, and that's it. Still working on your treatment.
Yeah. Well, I love this entire conversation. Where can people find you? Where can they follow you, learn more about you?
Well, we are in Mexico City, as you know. We are in
Mexico City.
In Mexico, so it's big, but we're a nice place. It's called Arcos Bosques, pretty secure, and something is lovely. We receive patients from everywhere in the world.
I know. I was in the waiting room and ran into people who follow me on social media who were coming to see you. And I'm from various countries throughout the world. And I was every time I'm like, this is so amazing to see so many women coming here.
Yes, it's amazing. And we have the first concept in Latin America because Nacere is in a building that shared in a mall with a hotel. A nice place is the Aqua. And you just go, most of our patients just arrive to the Aqua, walk around, and reach the clinic. In Mexico, we have doctors everywhere. So in Guadalajara, in Monterrey, so in the United States, we start with the sonogram that's so easy. So you don't have to be here for 2 weeks. And at the end, if a retrieval is Saturday, you arrive by Friday night, perform your egg retrieval, and by Sunday, you can live everywhere. So it's very easy.
Yeah. It is. And you have a wonderful clinic. I love your staff and I love your KPIs so much. But thank you for taking the time. I know you're very busy, but I adore you and I appreciate this conversation so much.
A pleasure. And for me, it's just if I can give you something that help you to make a different decision, is so good for me. Thank you so much.
I hope you enjoyed this episode. If this is the kind of content you're into, then I highly recommend checking out this.